File-resistant bacteria?
Huh?
File-resistant bacteria?
Yeah. Go for it.
Okay. Lactobacillus?
Sure.
Bifidobacterium, longus, and then Lactococcus lactis, and then Lactobacillus salivarius. Are those it?
Yeah, these are they're resistant, but they don't usually cause cholecystitis. Yeah.
I got E. coli, Enterobacter, Foca, Enterococcus bacillus, and Klebsiella.
Klebsiella is okay, Enterococcus fecalis is okay, and E. coli is okay. Two more. You're missing two more.
Yeah.
Salmonellus, possibly, yeah.
I got
Which one?
Bifidobacterium.
Bifidobacterium, yeah. Sure. One more. You're missing one. Huh?
Clostridium.
Clostridium would do it too. Yeah. Good. Huh?
Lactobacillus.
Lactobacillus. Lactobacillus, it doesn't really, yeah, it's resistance, but it really wouldn't cause it. One more, guys. One more. Listeria, there you go. That's important. Listeria. E. coli, Listeria, Enterococcus fecalis. These are the three most important ones. Yeah. Which one? E. coli. Listeria is Listeria. Monocytogenes. Her last name is monocytogenes. Okay. So that's E. coli, Listeria monocytogene, and Enterococcus fecalis. These are all gram-negative, but you can, Enterococcus fecalis gram-positive. Clostridium, you can include it too. It's okay. But Listeria and E. coli by far. Okay.
Wait, Listeria is gram-positive, right?
Gram-positive rods. Anything else? Any other bacteria? Give me all the names that you have or whatever. Maybe it'll ring a bell in my head.
E. coli,
Yeah.
Coccus, Listeria, monocytosine, and then Clostridium.
Clostridium. Anything else that you guys? What did you find?
I don't know, glycerol. Hold on.
Glycerol?
No. No, I do think.
Actually, glycerol eating bacteria. Yeah, if you know the name, that's true as well.
S-typhi wasn't a little bit.
Which one?
S-typhi or typhi?
Salmonella typhi. That's salmonella. Yeah. Typhi is actually no longer existing, at least in the developed countries. Any other? You didn't do your homework, right?
I did. Streptogram B? I don't know.
Streptococcus?
Streptogram.
There's no such thing. Maybe you're talking group B Streptococcus.
No, Streptogram.
That's a bacteria out of my universe. All right, good enough. Yeah.
I also have the portal vein anastomosis.
Yes. Please tell me those. Good.
For gastroesophageal junction, it's the esophageal branch of the left gastric vein, which arrives from the portal vein, and anastomosis with the esophageal branch of the azygos vein, which dumps into the superior vena cava.
And which is what? What's that branch?
The azygos vein.
So there's two systems: portal system and
And the system.
caval system, which is azygous vein. Now the branch of portal is left gastric vein. What's the branch of azygous vein?
Esophageal veins.
Right gastric vein.
The right gastric vein.
Right gastric vein. Okay, so left gastric vein is from portal system.
Splenic.
Well, splenic, it's part of splenic, yeah. So those, all of them, they will combine, they will give you plexus. They're on the esophageal plexus. Okay, so good. And the umbilical one?
The periumbilical one is the periumbilical veins that arise from the left branch of the portal vein. The anastomosis with the inferior epigastric vein that arises
Excellent.
from the great stephanus vein, which turns into the femoral vein.
Excellent.
And then
Don't forget the left gastric, the hypogastric vein. Don't forget that. Okay.
And then rectal is the superior rectal vein, which arises from the inferior mesenteric.
Mm-hmm.
And anastomosis with the middle and inferior rectal veins, which arise from the internal iliac vein and the internal pudendal vein.
Good job. Perfect. Okay. Anything else? All of you okay with that? Okay. All right. Now, so Zach had a question. Let me go over that first, and then I'll go over something else. There you go. This how I enlarge it. Yeah. Okay. Now the zone, Zach's, the zone in the lobule are based on the distance from portal vein to central vein. Okay, so the proximal area to the portal vein is zone 1, and then the zone 3 is closer to central vein. This is actually central hepatic vein, which carries deoxygenated blood. Okay, portal vein brings nutrient-rich blood from intestine. Okay, zone 2 is in the middle. Why is that significant? We don't really have to know the zones. It's a great idea to know them, but it really doesn't matter. Now, the question is, if somebody has heart attack, you patient, you were saying, right? If they have ischemia, which area is most likely affected? Mm-hmm. So which zone? Zone 1. What will happen to zone 1? What's your question? I'll come back. That's good. Keep thinking. I can't hear you good. Before extraction? If you want to remove the whole liver? Oh, of course. But then you just have to clamp the portal vein and hepatic vein, both. Yeah. That's all. Yeah. You don't care for zones anymore because you're removing the whole liver. It's not an issue anymore. Yeah. Zone is only for identification, for simplicity. This has nothing to do with, in terms of removing the whole liver. That's the least of our concern. All zones are affected. Okay. Yeah. Okay. Now there's the thing. There's two things. When you want to remove the liver, let's say you have to clamp the hepatic artery, which is more important than vein. Why? Because it's high pressure. Okay. Clamp the hepatic vein. By then the central vein become hepatic vein and then portal vein. Before they enter and before they leave the liver, like not inside the liver, you clamp it outside. The best location to clamp the portal tride is which location? Very good. And what do we call that? Margin. Free margin. You can actually put your finger and clamp it. And behind that margin is what? Lesser omentum. Right? Or lesser omental sac. Okay. Now, let me ask you again the same question. So, let's talk about two things. Right heart failure and left heart failure. How would this be affected? Yeah. Let me make it easier. Let me make it easier. Okay, so let me make it easier based on zones. Let me make it easier for you. If somebody has, we'll talk about Chiari syndrome today, hepatic vein thrombosis versus septic shock or shock. What will happen?
Shock will decrease blood pressure.
Okay.
And increase heart rate.
Okay. How would the liver be affected?
The liver will be enlarged, swollen.
I'm saying if somebody has a shock, okay, and another person has hepatic vein thrombosis. Okay, a girl has hepatic vein thrombosis. She's smoking, she's taking birth control pills. How would her liver look compared to somebody who has shock?
Shock is opposite of portal hypertension.
I'm not saying anything. I'm just saying based on this area, what would happen?
Oh, based on the diagram?
Yeah.
Well, in shock, everything will be dilate. Right?
Okay, when somebody's in shock, what's the big deal? Do you pass out?
Hypovolemic shock.
When you lose a lot of blood, do you pass out?
Yeah.
Why?
Because there's not enough blood.
Hypovolemic shock.
Why do people pass out?
The pressure drops.
They're depressed?
There is no enough.
So what if the pressure is dropped?
There's not enough blood flow to the brain and the organ.
Okay, for brain to stay conscious, it needs what? Oxygen and nutrient, especially oxygen. So if you don't get enough oxygen to the brain, what happens? It shuts down. Now, what will happen to the liver? So if somebody is in shock, I mean the brain is not getting, how about the liver? Thank you very much. And I love the heart.
It's not from me.
Chris?
Across the street.
Oh. Who's Chris?
Christian.
Who's Chris?
Christian.
Chris is right.
That's a guy's name.
Have you thought of it good, man?
It's the girl.
Oh.
Pancake house.
Okay. Pancake house. There you go. Thank you.
It's playing all of you.
Me and Ahmed like to get played. It's okay, right? Yeah.
Nobody can
We're okay. Superman don't mind getting played, right? We can handle it, right? Thank you. All right. So there you go. Now the thing is, if somebody is going under shock, that means there's hypoperfusion. Perfusion is affected. The liver will not be getting enough blood and oxygen. What's the artery that supplies liver with blood and oxygen? Hepatic artery. So which area, zone 1, zone 2, zone 3 is most likely to go under ischemia?
All of them. All of them.
Which area is the furthest away from hepatic artery? Zone 3. That's the area that will most likely go to necrosis first. Zone 3. If somebody has hypovolemic shock, heart attack, or anything like that, when there is lack of perfusion to the liver, zone 3 will go under necrosis. And that's known as centrilobular. It's the center of what? The lobule. The center of lobule is what? The central vein. Centrilobular necrosis should be expected when? When somebody has hypovolemic shock, heart attack, and things like that. Or decreased blood perfusion. How about centrilobular edema? It's the opposite now.
Oh, no.
No. I'm still telling you centrilobular. The center of lobule.
It's portal hypertension.
Not portal hypertension.
Oh, no, the hepatic vein thrombosis.
Yeah, hepatic vein thrombosis. Okay? Or right heart failure. So sometimes we can differentiate between right and left heart failure based on centrilobular. This is the center of the lobule. Zone 3, centrilobular edema or centrilobular necrosis. If blood is being obstructed here, most likely fluid is going to leak where first? Zone 3 first. It will take time for it to get to zone 1. Okay? Portal vein obstruction will call zone 1 edema, which is rare anyways. Okay? Alright. Good.
This is not showing on the street.
Huh?
This is not showing on the street.
Oh, it's okay. We don't need it. Okay. Now, whoa. What happened?
Did you?
There you go. This is okay too. It's running. Okay. This, because it's a new thing now. Okay. Liver. We discussed cirrhosis, right? We discussed cirrhosis. What could lead to cirrhosis? Almost any diseases. But some conditions are more common. Toxins that cause cirrhosis. This could be infectious toxins. Infections. It could be drugs. It could be alcohol. Okay? It could be radiation. It could be diet. Fava beans, for example. Aflatoxin, for example. It could be also genetic diseases. Okay? Let's at least go to infectious diseases. Okay? Infectious diseases. Oh, you know what? Let me go over jaundice first. Because I think that's more critical to understand jaundice. What is this thing called jaundice, right? Let's do jaundice first. John Dice. Yeah, Dice John. Okay. Now, when you think about jaundice, you can come with your own conclusion about jaundice. Number one, the first thing is jaundice is nothing more than accumulation, abnormal accumulation of what? Bilirubin, where? In the skin, conjunctiva, or sclera of the eye. That's where you see it, but it can be anywhere else. Okay, so jaundice is yellow discoloration. Yeah, jaundice means nothing more than yellow discoloration of the skin. Good? Therefore, if it's yellow discoloration of the skin, what is the cause of that? There's a pigment, yellow pigment, called bilirubin. Yeah. What if you get orange tan? You know, like when you go to salon and tan, they give you orange discoloration. What's that? That pigment that gives skin orange color. Thank you.
Carrot.
Carrots. So they smash carrots and give it to put in your skin. Carotene. Good job. Good job.
It's true.
No, you're right. You're right.
My daughter.
Keratin is found in carrot. Okay, so that's one. Dark pigmentation. What gives you dark pigmentation? Melanin. What gives it brown pigmentation? Write it down. This is important. This is important because it seems very simple, but that's a question. That's a question. So we talked about yellow. You're okay with that, right? Bilirubin. Orange, carotene. Dark, melanin. And then what else? Brown pigmentation.
Iron.
Oh, congratulations, my friend. Good job. Iron it is. Iron. Yeah. Iron. Okay. All right. We good? So let's talk about this yellow pigmentation of the skin known as jaundice. Now, all of you know that we have liver. Bilirubin is produced where? Where is bilirubin produced, first of all? Bilirubin, biliverdin is produced in plasma and in spleen, both. Okay? Alright. Now, but that's unconjugated bilirubin, correct? Okay. I think you have a beautiful picture in your book, don't you? Or maybe that's in the RBC section. Sorry, guys. Sorry, guys. In RBC section, we have this. Whoa, what happened to me? Something is... Nope. How did I do that? Where is the toolbar? There you go. It's toolbar. Something is missing. It's this one, right? No, this one. There you go. Found it. Thank you. Okay. So, in plasma, what do we make? We make bilirubin, unconjugated bilirubin. And this bilirubin, this unconjugated bilirubin has to be, so let's say unconjugated bilirubin is then transported where? To the liver. Very good. To the liver. With the help of albumin, bilirubin has to be carried in plasma because it is insoluble. Unconjugated bilirubin is insoluble. Conjugated is what? Soluble. So the whole purpose, the mechanism of in making bilirubin less toxic is conjugation. And who does the conjugation? Liver. So liver, once it conjugates this bilirubin, then it will secrete it in what? In bile. Excellent. Okay, it will conjugate it and secrete it in bile. So let's say then this bilirubin is carried by bile. And bile will secrete this bilirubin where? Duodenum. Excellent. Now it's conjugated bilirubin. So one name for unconjugated bilirubin is? What's another name for unconjugated bilirubin? Indirect. And what's another name for conjugated? Direct. Good. Okay. Awesome. Excellent. Good job. Okay. You can see my obsessive compulsive behavior, but don't ignore it. Now, second thing we need to know. The enzyme in liver. The enzyme in liver. Enzyme in liver that conjugates bilirubin. We need to know the name of that enzyme. UDP, glucuronal transfers. Congratulations, Muhammad. Yeah. When I watch Hindi movies, they're like, "Your Honor." The way they say it different, like, you know, those. And then there's somebody wearing the cloak, and he goes, "Chew." The hair goes backwards, like, and thunder goes at the same time. The way he speaks. I love that actor. I don't know what his name is. He's a bad guy. He's in Over the Top with Sylvester Stallone too. He's like Kalima Shakti Day. You know who I'm talking about, guys? Watch this movie in the 80s or I don't know, 60s or 70s with Sylvester Stallone, Rambo, the Rambo guy. The bad guy in the movie is an Indian actor. He's an amazing actor. So he goes like, I'll get you the clips. It's interesting. All right. So, glucuronal transferase. Are we good? Okay. Now, to understand this, I just want to go a little bit more in detail. Just please forgive me for taking too long. What does heme look like? Heme looks like this. See that ring? There's an iron in the middle. Excellent. This is heme. Heme is toxic. Extracellularly, it's toxic. The only place where you should find heme is where? Within RBCs. Outside of RBCs, it's not a good thing. So when RBCs are lysed, they're dead. All the heme is then secreted. So you have to get rid of it out of the body. But heme by itself, this is a lipophilic molecule. It can cross all the membranes. It can go to brain and other places and cause problems. So we want to get rid of it. It's toxic. First thing you want to do is splenic macrophages will open this ring. You see this is a ring, right? Okay. It will open it and it will become an open ring. It will look something like that. It has all these double bonds. You know, double bonds absorb a lot of light. And that's why you can do phototherapy, can resolve unconjugated bilirubin. You know? Because it absorbs light and it changes, it makes it soluble. So, unconjugated bilirubin, what's the treatment? Phototherapy. That's why children, when they're born, you keep them under what? Under light. Why? Not psychological, because in the womb it's dark. They love dark. For this purpose.
Also, they can't really see when it's
The liver is not mature yet, yeah.
Is it called psychological or something?
Oh, thank you. I see what you're saying. Not psychological, physiological. Physiological jaundice. Write this down on the side. Physiological jaundice is normal in babies. In babies, newborns, I shouldn't say babies, newborns, the first 2 weeks, if they have jaundice, it's normal. When a newborn is brought into your clinic or to your hospital, I mean, if you guys get a hospital and clinic, till now on the exam, when you see a question is talking about a mom brought her newborn baby, and this baby had jaundice, and of course they're less than 10 days old or less than 2 weeks old, it's normal. What are you going to tell them? Go home. It's okay. The liver is not mature yet. Huh? Yeah, no. I mean, you don't have to do that. Just tell them go home. This light is good enough. Yeah. Okay. Sunlight, you know, like babies, newborns, you have to be. It's a huge change. But anyhow, you just send them home. Tell them like in 2 weeks, if it doesn't get resolved, bring him back. Okay? Alright. Now, you see this is still an open ring. It's insoluble. Now, we want to conjugate it. Liver will add to its sugar molecules. We'll add a sugar. So this open ring is known as biliverdin. And then it's oxidized and it becomes bilirubin, unconjugated bilirubin. So conjugation is when you add this sugar molecule, 2 of them. And that's now it's conjugated bilirubin. Who does that? Liver. Liver. But this sugar has a UDP attached to it. That's why you call it glucuronal UDP transferase. The enzyme is transferase. Transfers UDP glucose to what? To unconjugated bilirubin. Good. So liver does that. Excellent. We're done. So please remember this enzyme. Don't forget. Now the question is, as long as bilirubin accumulates in blood, it is likely to go where? In deposit in skin. A lot of your blood goes through your skin. Why? Yeah, the largest, the biggest organ in terms of mass and size. Okay, and it's highly vascular. And of course, you know, it takes all the heat away from where? From your body. Blood has to go to skin to deposit heat, and it's a lot of functionality. But regardless, so skin should be highly perfusible, and it is. Okay. Now we have 2 areas. What if something is wrong in the blood? So hemolysis. One cause of jaundice can be extreme hemolysis. Too much hemolytic anemia. Too much hemolysis. One problem you can have jaundice is nothing to do with liver. It is a vascular problem. Hemolysis. Hemolysis means bursting, killing, or rupturing of RBCs. Okay, and it's so that's one. Another thing could be there's a problem where? In the liver itself. Maybe the enzyme is deficient. Good. So liver. There's a liver problem. Another problem is there's a stone maybe or a mass obstructing bile flow. So there's 3 causes of jaundice overall. In each category we'll have multiple causes, right? So now, if you think about it, we will call something before the liver. Blood is before coming to the liver, right? So we'll call that prehepatic jaundice. And then how about obstruction? What would you call that? Post-hepatic. And what would you call the hepatic one? Hepatic or intrahepatic? Very good. You see, overall, jaundice has 3 causes. 3 causes. Or jaundice falls under 3 categories. Causes are multiple. Okay. So prehepatic is simple. It's always what? Hemolytic anemias. Almost always it's vascular problem, hemolytic anemia. Next semester we'll discuss hemolytic anemias more in details. Okay? That means hemolysis should be so much that the liver cannot take care of it at the same time. There's more bilirubin produced than conjugation can occur. So the liver is overwhelmed. Okay? The liver is overwhelmed with this production of bilirubin, and the liver doesn't have the capacity to conjugate so much unconjugated bilirubin. So the hemolysis is occurring at such a fast rate that the liver cannot handle it. That's prehepatic. Okay? So in prehepatic, what would you have? Unconjugated bilirubin emia. Emia means in blood. So there's increased unconjugated bilirubin where? In blood. Okay, so unconjugated bilirubinemia in blood. Remember that. So I'll just to tell you this, in this case you will have unconjugated bilirubinemia. I'll put UB. Okay. So unconjugated bilirubin is increased. Conjugated bilirubin is normal. Total bilirubin increased. As far as I know, I might be right, I don't know, you can check. I think bilirubin should be about 1.2 total, 0.8 is conjugated, and 0.4 is unconjugated. So in this case, unconjugated bilirubin will be much higher. Conjugated bilirubin will be normal in blood. And total bilirubin has to be increased because at least one side of it is increased, right?
Can you have too little bilirubin?
Huh?
Can you have too little bilirubin?
Too little? Yeah.
So what other function does it have besides?
Well, that means you're not able to produce RBCs, and that's the least of your concern by then, because
Can like the enzyme be overactive and chewing through it much faster?
no such thing. No. Yeah, that's okay. That's a good thing. Yeah. Okay. Now, let's talk about post-hepatic. Post-hepatic bilirubin is always obstruction, right? Obstruction. And most of the time it is what? Stones. So let's say stones or a mass or a tumor. Maybe pancreatic head tumor. That's post-hepatic. Okay. As long as any bile duct is blocked, genetically, inflammatory, or by stones or by mass, any obstruction of not intrahepatic bile ducts, guys, extrahepatic bile ducts. Okay, extrahepatic bile ducts, not intrahepatic, because there are bile ducts that originates where? What's the origin of bile ducts? Yeah, bile canaliculi. They become ductules and they'll combine to make ducts, and then eventually one large duct, right? Okay. So in this case, unconjugated bilirubin will be normal or slightly elevated. Okay, so let's just say for much, I can say normal, yeah. How about conjugated bilirubin? Much higher. And total bilirubin? Increased. In the intrahepatic, that means the liver is either inflamed or going through cirrhosis. So its capacity, there's so many things in this hepatic. Any liver disease can lead to jaundice, right? So in this case, what you will have is you will have unconjugated bilirubin high. So would you have conjugated bilirubin high, and then you will have total bilirubin high as well. Okay, so now the conjugated bilirubin, depending if there's cirrhosis or not or something like that. Okay, so look for those things.
How would both be going?
Well, in hepatic, because when the, for example, in hepatitis, the hepatocytes are swollen, so secretion is decreased. As a result, bilirubin will pile up. And then the one that's conjugated, so number one, it can be decreased in conjugated or increased, but the unconjugated always elevated.
So why would it be increased in conjugated or decreased?
Now, conjugated, if it's obstruction, yeah. So that means number one, the enzymes are deficient themselves, and then it's also obstruction, so it's piling up. It's not that it's converted faster.
Okay.
Yeah.
In your post-hepatic, wouldn't the unconjugated bilirubin also be increased because it's getting back up?
To the point that yes, essentially it will, but not initially. Initially, you will just have conjugated bilirubin that's increased because enzyme activity is not affected. When it becomes chronic, yes, it will affect the enzyme activity. Acutely, no. Yeah. Liver is fine. Liver is doing its job. Okay. So in that case, okay. At the end of the day, you know, jaundice is nothing more than what? Discoloration of skin. You just need to identify the causes. And if it's obstructive, whenever there is obstructive jaundice, expect light stool and dark urine. If it's obstruction.
It's only an obstruction.
Primarily because, you know, if it's hemolytic, you can have dark urine and partially dark stool because there's no obstruction, so you still secrete bile where? Into the duodenum, yeah. It's obstruction that will deprive stool of,
The color.
yeah.
Okay. And for intrahepatic, conjugated is increased just due to obstruction also, right?
Yeah, in intrahepatic primarily it will be unconjugated, depending, again, if intrahepatic cause is destruction of enzymes, there will be unconjugated more. The ratio will be in the favor of unconjugated. If the problem of intrahepatic is duct obstructions, intrahepatic duct obstruction, then it will be what? Conjugated more. So the ratio will help you to determine what's the cause. Yeah. All right. Let me give you an example. Look, if we have, if you see the ratio of conjugated bilirubin to unconjugated bilirubin, it's high. It's telling you that it is more conjugated bilirubin compared to unconjugated. So in this case, it's most likely obstruction. Yeah. Okay. So if you have both of them increased, it's either chronic or intrahepatic. Okay, chronic obstructive or intrahepatic obstruction. You can also have extrahepatic obstruction that's in long term, like how Nina was saying it.
So this is how you calculate the ratio.
Depends how I give it to you. If I give you UB over CB, and that's increased, that's a different concept now. So you have to pay attention what ratio we're talking about. Okay. In this case, if unconjugated is increased, it has to be increased compared to conjugated because the ratio overall is increased. So that's most likely vascular problem. Yeah. Okay. And you guys know ratios. I mean, it's simple, straightforward. Okay. Let's go to hyperbilirubinemia, and then we'll take a break. Hyperbilirubinemia, and let's call this hereditary hyperbilirubinemia. Inherited hyperbilirubinemia. Inherited. Hereditary hyperbilirubinemia. Okay. There's 4 diseases that come under this category. 4 diseases. Okay. 4 diseases. Now, hyperbilirubinemia can be of 2 types, right? What are the 2 types? Good. Yeah, I mean, sure. Yeah. Hani's never wrong. I just don't know why he hesitates. Don't hesitate. Ahmed, tell him.
They both need this
So-
conversation. They both need to tell each other that.
So we can have unconjugated. hyperbilirubinemia, and we can have conjugated hyperbilirubinemia. So there's two types. I mean, there's two possibilities anyways. Remember, these are familial, or these are genetic or inherited hyperbilirubinemia. I didn't write inherited, so you can write that hereditary hyperbilirubinemia. Please write the whole thing. Hereditary hyperbilirubinemia. Yeah.
In which fashion?
In which fashion?
Autosomal dominant.
Oh, I'll tell you. Each one is different. There's four diseases all come in that category. Okay. Now, in unconjugated bilirubinemia, there's two diseases that will give you this scenario. One is Crigler-Najjar syndrome. Okay. That's one. And the second one is Gilbert. Where's the L? Gilbert syndrome.
Anderson.
Okay? Huh?
Anderson.
No. Anderson is, remember, it is glycogen storage disease where you cannot make glycogen. It's a branching enzyme deficiency. Now, you're close. Those are glycogen storage diseases. Brother, we're done with those. We're done with those. I'm not going to repeat the same disease twice. Just at least take it that way. The next one is Rotter syndrome. Rotter syndrome. Okay? And one more. Dublin. There's Dublin pizza, right? This is not Dublin, this is Devon Johnson. Devon Johnson. Huh?
Isn't Dublin also a city?
Yeah, Ireland, Northern Ireland. Yeah. Okay, so these are the two for each. Are we good? Okay, thank you very much. I'm trying to make it easier for you. Now, in Crigler-Najjar, let me tell you this, it's autosomal recessive inheritance. Both of these. What do you think would be deficient then? Thank you. What's the enzyme then? Gut. There you go. Congratulations. So this is UDP, glucuronal transfers, or glucuronal transfers enzyme deficiency. And both of them. How is it different then? In Crigler-Najjar, it's complete deficiency. C for what? Complete. C for complete deficiency. C for complete deficiency. In Gilbert, it's what? Partial. So there is gut activities decreased. Not necessarily it's complete deficient. So Gilbert is maybe carrier, and Crigler-Najjar is complete deficiency. It's homozygous recessive. Are we good? Congratulations. Good job. Okay. Now, who's at risk? At the end of the day, both of them are jaundice.
Yeah. And both are autosomal recessive.
Yeah. So, which one is more severe?
Oh, Crigler.
Crigler. Complete deficiency, right?
Yeah.
Therefore, C for complete deficiency. C for conjugation defect. All C's make sense now. C for conjugation defect. C for children. And C for complete deficiency. Okay? There you go.
So Gilbert wouldn't really show children?
Now I'm coming to that. Yeah. Okay. So C, Crigler-Najjar should be jaundice when?
Child.
Within 24 hours of birth. Expect jaundice for Crigler-Najjar within 24 hours after birth. Within 24 hours. Now, if you're suspicious, again, you will be thinking of physiological jaundice, right? Within 24 hours. You're like, it's... Now, physiological jaundice usually occurs when you start breastfeeding the baby. Because then the fatty, the albumin is occupied. There's not enough albumin to carry. Plus, in addition to that, the liver is immature to conjugate it. Okay? So usually within first 24 hours, you shouldn't see physiological jaundice. Most likely physiological jaundice will be seen after 48 hours. So when you see jaundice within 24 hours after birth, you should be suspicious, especially if it's pronounced jaundice. Mild jaundice, maybe you can let it go. Yes, sir. Okay. For Crigler Najjar, it's complete deficiency of glucuronal transferase enzyme, which is responsible for conjugation. Okay, so I tried to memorize it. C for conjugation defect. You cannot conjugate bilirubin. C for children. Okay, and C for complete deficiency. Okay. All right. Now, what can we use G for? Excellent. Good job. So, Gilbert is partial deficiency. Unless you are under stress, you won't have jaundice. Unless you're under stress, you shouldn't have jaundice. The only time you will have jaundice is if your liver is overwhelmed with what? Unconjugated bilirubin. So when would that be? When you exercise. Good job, Nina. When you exercise, or when you're ill, or you have hemolysis. When you work out, what happens to your RBCs? They go through hemolysis. Why is that? What happens to blood flow when you exercise?
Pressure increases.
So what does that mean?
Puts a lot of stress on the
Normal blood flow is called what? What's the term for normal blood flow? See, normal blood flow goes in straight lines. Okay, so let's say this is a blood vessel, right? Due to friction, blood flow here might be a little bit rough on the edges, but in the center it is what? Linear. In the core of blood vessels. The wall of blood vessels will cause some friction, maybe a little bit turbulence, but this is called lamellar flow. Lamellar flow. Lamellar means organized in straight lines. What is turbulent blood flow then? That's not lamellar. So it's all over the place. And it's turbulent flow that causes hypertension, that causes aneurysm, that causes problems, because it will cause erosion of blood vessels, right? You guys have gone to rivers, right? You know when a river curves suddenly, what happens to the bank? Let me tell you something about, let's say 10,000 years ago, when Pharaoh used to exist in Egypt. I'll talk to my Egyptian friends.
Grand Canyon.
The Grand Canyons, I have not much, so I know the Nile River. It was like this 10 years ago. Now, it's like this. Why is that? With time, remember, it will keep eroding and eroding. It will keep going like this. And eventually, it will close off. Erosion, it will become more linear. Okay? Because the bank will keep heading with water and water. Same thing with this. So, in this case, when we talk about turbulent blood flow, what happens to RBCs? They bang against the wall of vessels and they rupture. So when you do too much exercise, for example, boot camps or marathon running, or Ahmed and Muhammad running and chasing each other, you know, this could happen.
You step on the floor, you're also gonna squish it.
Yeah. And then there's also traumatic injuries when you wrestle, when you punch each other, when you do things like that, or when you do muscle activity, heavy exercise in bodybuilding, you can actually cause hemolysis. Yeah. Okay.
Like it's a disorder for like people who walk too much and they get too much hemolysis.
Yeah, it's anemia of traumatic hemolytic anemia. Okay. So now, are we okay with this? So Gilbert will be exercise-induced jaundice, activity-induced jaundice. Now, we talked about G. G for what? Gentlemen, right? And let's use G for gym-induced jaundice. Okay, just to help you to remember. Okay, gym-induced, gentlemen, meaning adults. Usually won't have jaundice unless you do some stressful activity, not mental stress, physiological stress. Okay. At the end of the day, both will have what? Unconjugated bilirubinemia and jaundice. And how are you going to differentiate? Based on age. How would you differentiate? How would you confirm the diagnosis? You will take biopsy of the liver and you will look for the enzyme to see if it's partial or complete deficiency. You have to do enzyme assay and you have to do DNA test. Okay, are we good? All right. And what's the therapy for this? Phototherapy. Phototherapy. Okay. Enzyme assay and DNA test. Yeah. Okay. You can do actually blood test first. So first you will do what? Plasma test. And what would you see? Unconjugated bilirubinemia but you don't know which one it is. You know if it's an adult, most likely it's Gilbert. If it's in children, most likely it's what? Crigler-Najjar. But guess what? Further than that, you have to do enzyme assay. And then what would you do?
DNA test.
Yeah, DNA test. And you can do DNA test by what?
Fish.
By gel, by fish, by multiple different ways. You'll determine the gene is deficient. Okay. Enzyme assay only tells you activity. It does not tell you if it's, maybe if there's zero activity, it's complete deficiency. If it's partial activity, it's partial deficiency. So just to confirm, you might want to do a DNA test as well. Okay. Are we good with this? Let's move on to these two. In Rotter syndrome, are for releasing. Now, think of it secreting, okay? It's actually secreting. It's secreting. So you cannot secrete bile. You can conjugate bile. No problem. The enzymes are proper. The hepatocytes are proper. They're functional. But once the hepatocyte conjugate bilirubin, what happens then? It has to dump it where? Into the bile canaliculi, bile ducts. So that means you cannot transport conjugated bilirubin from hepatocytes into bile ducts, bile canaliculi. So I just use R for releasing, just to help you, that's all. But it's actually secreting. Okay? It's active secretion. For Dubin-Johnson, dumping, which is the same thing. Okay? They're both the same thing. They're both secretion problems. You can conjugate, but you cannot secrete into what? Into bile canaliculi or ducts. But in Dubin-Johnson, I like to use D because the hepatocytes will stain dark. The hepatocyte will stain dark. The only way you can differentiate Dubin-Johnson from Rotter is if you do biopsy of your liver. And when you do the biopsy, you can stain them, and the Dubin-Johnson hepatocytes will stain dark. They have epinephrine full granules and other granules that stain dark. Okay, so that's unique for that. Other than that, you cannot differentiate. But immediately you should know if it's conjugate or unconjugate on plasma test, blood test. Okay, if it's direct bilirubinemia or indirect bilirubinemia. And then further you will go if it's in children or Gilbert, and then you will go if it is dark staining hepatocytes or non-dark staining. Okay.
So their conjugate is also autosomal?
Oh, rather the exact cause is not known. For Dubin-Johnson, there is a transporter which is autosomal recessive or dominant. It could be both. Yeah, depending if it's the enzyme part of it or the channel part of it. Yeah. All right, good enough. Let's take a break. These are important. These, especially pay attention to Gilbert.
Treatment will be the same?
Huh?
The same?
Yeah.
This Gilbert will be confusing, right?
Gilbert is more common.
It's more common, but it's more mistakenly diagnosed.
Guys, why is Gilbert more common?